I just wanted to kind of go over how we look at spine imaging, how we come up with the differential diagnosis, kind of like the tricks and tips that we use as radiologists to come up with differential diagnoses. So our routine spine MRI protocol has a sagittal T1, sagittal T2, and STIR. And we also get axial T1s and axial T2s. So that's our routine protocol. That's going to be pretty standard throughout most institutions, I think. And the way we tell which sequence is which is the T2 and the STIR are fluid-sensitive sequences, right? So the CSF is going to be bright on those. STIR, the fat is suppressed. So this is a STIR sequence, and you can see that the normal paraspinal fat is actually dark. T1 is, the marrow should be bright on T1 because marrow is predominantly fatty. So for looking at abnormal marrow infiltration, you're looking for something that is T1 dark and usually STIR hyperintense. Okay, and I kind of just went over that. So this is kind of like our search pattern for spine MRI. We go through the counting reference, we look at the paraspinal soft tissues, we look at alignment, we look at marrow signal, and then the intradural space involving the coolness or the spinal cord. And then we go through the levels usually to see if there's any high-grade stenoses in the canal and foramina. Counting reference is very important for us and the neurosurgeons or the proceduralists because there's a lot of variation. We want to be able to make sure that we're consistent between our reports for localizing a lesion. So sometimes you can get like a transitional S1. What we try to do is we try to have our marker for L4, L5 be at the level of the iliac crests. And that way we can kind of be consistent. But just one thing to note that we do try to, say if there's transitional or non-conventional anatomy to make it easier to localize the lesion and reduce the risk of wrong site surgeries. Okay, so let's look at prevertebral soft tissues. Here's an X-ray of the C-spine, and what we can see here is there is really pretty extensive swelling or soft tissue thickening in the prevertebral soft tissues. And then if we look on CT, you can see that there is actually a prevertebral abscess there. Other things that we're responsible for as a radiologist is not necessarily just the spine. We have to look at everything outside of it too. So that's why it takes us more than like a few seconds to look at the spine. It takes us, a lot of time. Because why? Here's an example. This lesion was kind of in the side or the peripheral field of view, and if you're only focusing on the spine, it's easy to miss, right? This patient actually had multiple lung metastases that was caught on this MRI of the C-spine. Here's another example. So on the localizers, this was caught, and it ended up being renal cell carcinoma. And then here in the brain, there's edema. And this was also caught, and it turned out to be intracranial metastases. So just to let you know that your radiologist isn't just sitting having coffee or something. We're busy looking at everything. So going to alignment. So we want to make sure that these spinal lines are maintained in alignment. So here, we classify spondylolisthesis based from like grade 1, which is displaced up to 25%, grade 2, 25 to 50%, grade 3, 50 to 75%, and grade 4, 75 to 100%. And you should see these on our reports, and that's what it means. The atlantodental interval should be less than 3 millimeters in adults and less than 5 millimeters in peds. Here's an example. So this one looks kind of widened, and you can see the reason why is because this atlantodental interval is widened. The posterior arch of C1 has been moved anteriorly, and the cord is being compressed. Here's another example. This patient had achondroplasia, and you can see they have a developmentally small foramen magnum with foreshortened clivus in the C1 posterior arch, and it ends up like, they have very kind of severe stenosis here, and the cord is getting a little bit compressed there. Here's a trauma case related to looking for alignment. So here there is very subtle widening of the disc space anteriorly, and it takes like very subtle findings to kind of call and kind of warrants like a further imaging, like an MRI. And this is why, because this patient has a tear of the anterior longitudinal ligament with this effusion in the prevertebral soft tissues. And also, they have cord injury, cord contusion. Okay, moving on to abnormal marrow signal. There's a lot of different pathologies that can cause abnormal marrow signal. And so we try to kind of localize it based on the location, and if it's multifocal versus focal, and that way we can kind of come up with a differential for what we're seeing. So here is an example of diffuse abnormal marrow signal, right? And the way we know that it's diffuse and abnormal is because generally on the T1, the marrow signal of the vertebral body should be brighter than the disc space. Here you can see that the disc space is much brighter than the marrow signal. On T2, you can see it's diffusely dark. And then here, even on, like in the sacrum, there's this soft tissue here that's not supposed to be there. So this is an example of extramedullary hematopoiesis in the patient with red marrow conversion. So not everything that is abnormal marrow signal is metastatic or neoplastic, right? If you see something this diffuse, it could be an underlying hematologic disorder. Here's another example on the radiograph. Everything is diffusely sclerotic. Here's a bone scan, and this is what we call a super scan bone scan, because typically you're supposed to see uptake from excretion of the radial tracer in the kidneys and the bladder. And here we don't, because everything is being taken up by the bones. So it's called a super scan. And here's a corresponding MRI where the T1 signal of the marrow is diffusely dark. Again, you can see the disc space is brighter than the marrow signal. This is diffuse osseous metastatic disease. There's a focal area of marrow replacement. This is osseous metastatic disease, but it's involving one level, and this is what we call in radiology an ivory vertebra. Here's a lady who has osseous metastatic disease from ovarian cancer. And you can see that she has multiple levels affected. On T1, there's this dark signal where there's a superimposed pathologic compression fracture. Also in the L4 vertebral body, she has some osseous metastatic disease. And they have corresponding STIR signal hyperintensity on the STIR. So she ended up getting stereotactic radiosurgery to both of these levels. And this is her scan 4 months post-SRS. And typically what happens, not uncommonly, is when somebody undergoes SRS treatment to a vertebral body with osseous metastatic disease, the marrow that is being infiltrated kind of shrinks, and they are more at risk for getting compression fractures from the treatment. So one thing that we have been trialing at our institution and is, I think, probably available at other institutions is the use of DCE, dynamic contrast enhanced perfusion imaging of the spine. And sometimes that can be very helpful in helping us determine if a fracture is due to tumor progression versus treatment changes from SRS. So in this case, the L1 vertebral body had, compression fracture, but there's this epidural enhancement as well. The L4 vertebral body has a new compression fracture. So the question is this from progression or is it pseudo-progression from treatment change? So we use dynamic contrast enhanced MRI perfusion to help us kind of determine that. On the L4, there was no uptake of increased perfusion. But in the L1, where we saw that epidural enhancement, there is increased K-trans at that epidural disease. This was actually biopsied and positive for residual neoplasm. And the patient also had a PET, corresponding PET, and it also showed hypermetabolic uptake with the L1 lesion, but nothing with the L4 treated lesion. And then follow-up DCE MRI showed progression of the epidural disease. So it kind of was able to predict that this was progressive neoplasm and not pseudo-progression. Okay, moving on. So here's another question. All of the following are characteristics of Paget's disease except A, vertebral involvement that may be associated with compression fractures, B, cranial neuropathies that can result from skull involvement, C, Paget's disease does not demonstrate radionuclide uptake on bone scintigraphy, or D, both lytic and sclerotic bone lesions are imaging findings of Paget's disease. Okay, so it looks like close between answer C and answer D. So actually, both lytic and sclerotic bone lesions are imaging findings of Paget's disease, so that is correct. Paget's disease is actually, does uptake radial tracer on bone scintigraphy, and it's actually kind of a way for us to tell if it's Paget's disease because we can see it on a bone scan. So bone scan is sensitive for the detection of the increased blood flow and osteoblastic activity that accompanies the osteoclastic activity seen in Paget's disease. And here's an example of Paget's disease. So on the MRI, remember when I said that abnormal marrow is usually T1 hypointense? Well, if you have a lesion that has intrinsic T1 hyperintensity associated with it, like this one. See how there's kind of patchy intrinsic T1 hyperintensity? That is a sign that not all of the marrow is abnormal or infiltrated, and that can be a good indication that this might be something benign like Paget's disease. And here we can see on CT the squaring of the vertebra with kind of like the mixed osteoclastic and osteolytic osteoblastic process that we see on Paget's. Here's another example where we can see this is sclerosis and thickening of the vertebra, and it's the very confluent geographic involvement. So these are good cases of Paget's disease. Here's another case of Paget's disease where you can see mixed thickening, cortical trabeculation with inner areas of lytic lesions. So there's another case of Paget's. And finally, last case of Paget's, so mixed lytic and sclerotic lesions with widening of the diploic space in a calvarium. All right, so here's an example where the T1 signal is really dark, and on top of that, you also see extraosseous extension into the epidural space. When you see that, you know that it's probably not a benign feature, and this is actually a patient with lymphoma Lymphoma can involve multiple compartments. It can be intradural, epidural, or it can involve the bone. And when you see this amount of extraosseous epidural disease, one of the things that you want to think about would be lymphoma. Okay. And then this is just another example where there's intrinsic T1 hyperintensity associated with this lesion. Here's the lesion here on the T2. So that kind of tells us that it may not be, like a very malignant aggressive process. It could be a benign process. And on CT, you get this characteristic corduroy striated appearance of the bone. This is an example of an intraosseous hemangioma. Here's another example of an intraosseous hemangioma where on T1, you actually have kind of hyperintensity on T1. But this one is different because this one has an extraosseous epidural component as well. So this is an example of an aggressive osseous hemangioma. And on CT, you still see that characteristic polka dot corduroy type of pattern. But in this case, aggressive vertebral hemangiomas can progress, and they can result in impingement of the apical sac and the cord. And these are things that we actually kind of treat with SRS if possible. All right. Moving on. So we're going to talk about posterior element processes. So here on the CT, you can see there's expansion of the bone with internal kind of bony coalescence with expansion of the lamina and the spinous process. On MR, here's the corresponding MRI. There's like kind of T1 hypointensity with stir hyperintensity. This is an example of an osteoblastoma, which is expansile. It has that sclerotic rim. It contains internal mineralization and irregular bone. Okay. And then here's kind of a corollary case. This is a 34-year-old male with neck pain. And you can see that there's this kind of osteolytic lesion in the left inferior articular facet on CT. And on MRI, there's quite a bit of edema associated with it on stir. So these imaging findings, especially you can almost kind of make out like a tiny little nidus in there. These imaging findings are kind of like if somebody were to tell you, this guy has neck pain, it's worse at night, and it's relieved with NSAIDs. And I'm sure most of you would automatically say, oh, it's an osteoid osteoblastoma. It's like a Board's case, right? So for us, those imaging features, osteoid osteomas have a predisposition to cause quite a bit of edema greater than what the actual lesion is. And so that's a good clue for us. This person was treated with RF ablation, and he had resolution of his symptoms. Okay, another posterior element lesion here. So on CT, you can see this expansion of the posterior elements, the lamina and the spinous process. And you can see kind of like it's going a little bit extra osseously into the epidural space. On MRI, we have a very characteristic finding here, and that would be fluid levels. So there's only a few things on MRI that, or bone lesions that have fluid levels. So this is very characteristic for an aneurysmal bone cyst. The other thing that we want to keep in the back of our minds with fluid levels is this case where there are you can kind of make out fluid levels here, like here. And then there's this extensive bony destruction and kind of like osteoid matrix and extensive soft tissue involvement. And so this is the more aggressive kind of diagnosis that we want to think about, which is a telangiectatic osteosarcoma. Moving on to another posterior element thing. So here there is this kind of extensive soft tissue and bony involvement of the pedicle and posterior elements at L5. One typical feature here is how T2 hyperintense it is. And that is kind of like a sign for us, especially if you see on CT this kind of ring and arcs chondroid matrix. And this is a case of metastatic chondrosarcoma. Okay, and then finally we have this very well demarcated lesion that's expansile with like kind of bony sclerosis on the periphery involving the sacrum. So there's only a few things that kind of involve the sacrum like this. And then, there's enhancement on post-contrast imaging. This is an example of a giant cell tumor. And then here, we don't have the sclerotic margins, right? We have kind of like this erosive appearance on CT, and it's enhancing soft tissue on post-contrast imaging. This is a plasmacytoma. All right, this is another differential consideration for midline lesions in the sacrum or the lower lumbar spine. And it's T2 hyperintense. So there's two things that we think about for bone lesions that are T2 hyperintense: chondrosarcoma and this one, which is a chordoma. Okay. All right, moving on. Try to get through all these different categories. So let's talk about abnormal marrow that's centered at the disc space or the facet joint. So we have this categorization of different herniations. So you can have like a bulging disc, you can have a focal herniation. If it's a broad-based herniation, we call it an protrusion, sorry. If it's a narrow-based disc herniation, we call it an extrusion. And we try to kind of categorize them by like where they are. So, and one of the reasons is because we can kind of tell which nerve root it's impinging on based on where the location of the disc herniation is. So here's an example. This is a right paracentral disc herniation. And on the axial, you can see it's effacing the thecal sac, but it's also really narrowing the right subarticular zone. And if it's narrowing the subarticular zone, that's really where the descending nerve root is kind of traversing, right? And so that descending nerve root is going to get impinged. So that's going to be the L5 nerve root in this case. Here's another example of, in this case, it's the left side. You can see this nerve root is trying to go through. This is the left S1 nerve root, and it's getting impinged. Here, this patient has quite a bit of degenerative facet arthropathy. There's bilateral joint effusions and quite a bit of ligamentum flavum hypertrophy, resulting in severe canal stenosis. And more importantly, it looks like both of the subarticular zones are getting impinged. So that means that bilateral S1 descending nerve roots are getting impinged. And then here you have severe canal stenosis, and one thing that we like to say or kind of make note of in the impression is if there is cinching of the cauda equina nerve roots, if you see this kind of wavy pattern of the cauda equina, that kind of tells you the degree of stenosis that's further down. Here's an example of stenosis from ossification of the posterior longitudinal ligament. So this is a very common cause of stenosis in the cervical spine, and you can see that the posterior longitudinal ligament is very thickened and calcified or ossified in this case, and that would cause severe canal stenosis here, and you can see the cord is getting really impinged there. So discitis and osteomyelitis, usually if we see a normal appearing disc space with abnormal marrow signal on the end plates, they're most likely to be degenerative changes or Modic type 1 or 2 or 3 changes if the disc space is completely normal. What we start worrying about is if the disc space starts looking fluidy, it has fluid in it, it's enhancing, and then of course on the CT you see bony erosions along the end plates. So this is a case of discitis and osteomyelitis, which we see very commonly. Things that we like to make sure we can see is if there is an epidural abscess that might be compressing on the thecal sac and the cord. And these are the end plate changes, the Modic type 1, 2, and 3 changes that I was referring to. So you can see, like in these cases, the disc space is normally T1 hypointense. There's no fluid signal in the disc space, so that makes discitis very much less likely. And then degenerative facet arthropathy. So STIR is going to be very helpful in looking at abnormal marrow signal and edema. And so you can see on the STIR here, there is edema involving the facet joint, both superiorly and inferiorly. And there's corresponding T1 hypointense signal. So when we see this affected in this specific location, it's most likely going to be degenerative facet arthropathy. The other differential we would think of is this some sort of infectious process like a septic arthritis? In those cases, I'm sure people probably get annoyed at us when we can't always tell and we have to say correlate with clinical parameters. All right, so let's look at the thecal sac. We divide it into 3 different compartments. So extradural, intradural extramedullary, and intradural intramedullary. And depending on these compartments, we can usually easily come up with a list of diagnoses that it could be. So let's start with the intramedullary intradural compartment. So your most common primary spinal cord neoplasms are going to be ependymoma, astrocytoma, hemangioblastoma. And I have examples of all 3 of these. This is an ependymoma. And what is characteristic of ependymomas is that they tend to be cystic. They tend to have a solid component that's enhancing. They tend to have an associated syrinx with them. And they have what we call a hemosiderin cap, which means that they have blood products that kind of like layer at one end or another. And then the second differential would be an astrocytoma. And there is quite a bit of overlap between the 2 on imaging, but I'm showing you like the textbook cases. So astrocytomas tend to be more infiltrative, and they have very difficult margins to discern. Sometimes they have much less enhancement, and sometimes they don't enhance at all. So that's a kind of distinguishing feature from ependymomas. And then their enhancement is, if they do enhance, it's going to be very ill-defined enhancement type of thing. Hemangioblastomas, this patient, so usually you can see they're very like solid, nodular enhancing lesions. And on the T2 or STIR, you can usually pick out like little flow voids because they are very, very vascular. So a lot of times they're pretty easy to pick out. This patient actually has multiple enhancing intramedullary lesions that have associated cord edema. And so multiple hemangioblastomas, of course, this is what makes you think of VHL, von Hippel-Lindell's disease. All right, so this is another case. This is a not neoplastic process that occurs intramedullary, and this is a cavernous malformation. You can see it actually doesn't really enhance. Cavernous malformations don't usually enhance, but what gives it away is this characteristic surrounding T2 hemosiderin ring. And you can see that pretty well on the axial images. And here's an example of an intradural lipoma, and this is where MRI is very useful. It comes in handy because on the STIR, it's completely suppressed. So that tells us that this is all fat material, and so this is characteristic of an intradural lipoma. This is a case of a dermoid cyst. Now here you can see it's kind of more mixed, right? It's not like that lipoma where this is a lot more heterogeneous, but there are still areas of fat signal in here that suppress. So this is an example of a dermoid cyst. Other cord abnormalities. Here's an example of a KRE1 malformation. You can see this large cervical syrinx. This person was decompressed, but you can see their cerebellar tonsils are still a little bit elongated. And this is a case of demyelinating plaques in MS. You can see it's peripheral in location, predominantly affecting the white matter. Transverse myelitis usually affects more than 2 or 3 vertebral body in length. You can see this is this long segment of cord edema with mild enhancement, and it's going to be most common in the thoracic region. Here's an example of a cord infarct, and so you can see the central gray matter is involved, and we have this characteristic feature called the owl eyes or the barrel, double barrel finding. So this patient had cord infarct after repair of an aneurysm and dissection. Diffusion-weighted imaging can be very useful for detecting acute cord ischemia. Here you see all these flow voids. This is an example of a spinal dural arterial venous fistula. Okay. And here the dorsal cord is affected, and this is like a V-shaped, or the dorsal medial cord. This is an example of subacute combined degeneration. This patient had abnormal atrophy of the right side of his cord. And he was 20 years old, pretty young. He had ipsilateral thenar wasting. This patient had a disease called Hirayama disease, where you can actually diagnose on flexion MRI, because when you have a flexion MRI, you can see that there's distension of the dorsal epidural venous plexus. And that, in turn, displaces the dural margin of the thecal sac, and kind of the ventral margin gets kind of impacted. And that's where he has that kind of eccentric cord atrophy. All right, I think I'm running a little bit low on time. I have 10 minutes. Okay, we'll go through these quickly. So this is an example of a myxopapillary ependymoma. And here you can see there's enhancing intradural extramedullary lesion. And the differential for this, for intradural extramedullary lesions, would be a schwannoma, meningioma, intradural mets, or a periganglioma. This ended up being a myxopapillary ependymoma. And the thing with these is that if they are diagnosed as a myxopapillary ependymoma, we want to have whole neural axis imaging to look for any leptomeningeal or drop metastases. Here's another example of an intradural extramedullary lesion. And this person actually has had other lesions that were intradural extramedullary. He had actually schwannomatosis. Here's an example of a schwannoma. You have this characteristic dumbbell shape that extends into the neuroforamen. Schwannomas are the most common type of intradural extramedullary masses. This is actually an interesting case. These are very rare. This patient had a kind of like foraminal paraspinal mass. And if you were to look at this without kind of thinking about the signal characteristics so much, you would probably say, oh, it looks like a schwannoma. The thing with this one is that most schwannomas are going to be dark on T1, and they're going to be bright on T2. This one is actually kind of bright on T1. You can see this is the T1 axial image, and it is bright on T1. So that means that it has some material that is intrinsically T1 hyperintense. So this is melanin, and this is a melanotic malignant nerve sheath tumor. These are very rare, but it's important to know what they are because they tend to be progressive and difficult to cure. You can also have drop metastases as intradural extramedullary lesions. In this case, you can see there's an enhancing lesion along the distal conus. This patient had GBM, and so that was a drop metastasis from GBM, which is extremely rare. I don't know if you've seen that much at all, but here's another case, intrinsic T1 hyperintense signal, multiple lesions. This is metastatic disease from metastatic melanoma. So another reason why the signal characteristics are really important for us, because we can say there is melanin in here, and it was actually confirmed to be metastatic melanoma. All right, here in this case, you can see that there is patchy enhancement along the leptomeninges, and then in the brain, there is kind of enhancement coating the pons, the contours of the pons. This is a patient with neurosarcoidosis. So just so you know, there are other disease entities that result in enhancement of the cauda equina or intradural enhancement that may not be metastatic disease. This patient had multiple intradural extramedullary diseases, and what really helps us with the diagnosis is on CT, they're calcified. So this was meningiomatosis, multiple meningiomas. All right, we're getting close to the end of these. So this patient has severe headache, and you can actually, this is pretty striking. You see their cerebellar tonsils are very far below the foramen magnum, and they have kind of slumping of their midbrain. You can't really see the distinction of their midbrain. Their pituitary looks like it's enlarged, and they have this diffuse pachymeningeal enhancement. So this patient has classic imaging findings of intracranial hypotension. In this case, you know, we did a fluid-sensitive CSF myelogram, and we could see that there was CSF leak from a thoracic meningocele. All right, this is our last question, so I'm going to go ahead. Which of the following describing CSF venous fistulas is false? A, they are abnormal connections between the spinal subarachnoid space and adjacent paraspinal veins. B, they are easily diagnosed on CT myelogram imaging as pooling of CSF in the epidural space. 3, they are unidirectional with flow into the venous system. Or D, they are associated with, often anatomically associated with a diverticulum of a nerve root sleeve. And I kind of purposely made this a little bit trickier, so. Okay, so it looks like B is the most popular answer, and that is correct. They are actually very difficult to see on CT myelogram because it's hard to see, it's hard to catch the contrast flowing into the vein, the venous system. So the reason why I'm bringing this up is because this patient, I wanted to show this case, that was interesting. This patient had that intracranial hypotension, that severe intracranial hypotension. And on the CT myelogram, we can see he had like multiple nerve sheaths, like Tarlov cysts. So he had intrathecal contrast on the myelogram kind of accumulating in these Tarlov cysts. But we were not able to catch the CSF venous fistula. So what we ended up doing was a DSA, digital subtraction angiography, myelography of the CSF venous fistula. So that's like, you know, real time, you're imaging as the contrast goes through the thecal sac. And what we see here is very faint, but you can see that there's this connection between the Tarlov cyst and this serpiginous structure that ended up being paraspinal vein. And then on the spinal angiography, you can see this is much clearer now, right? You can see that it's going into the venous system. So this patient was actually embolized, and it's a striking difference. So this was pre-embolization, and you can see they even had cervical spine serrings from this severe intracranial hypotension. After the embolization, the tonsillar herniation pretty much resolved, and the serrings was markedly decreased. So it was a good case where radiology was able to kind of help the neurosurgeons localize this CSF venous fistula and help this patient out. All right, so key takeaways. Categorizing spinal pathologies by compartment can help narrow down the differential diagnosis. There's a lot of different imaging techniques, and there's always new ones coming out in both brain and spine. And so I think, you know, having an idea of what is available to you and us as radiologists is really important, because we would be much better able to help you with your clinical question if we know what it is, you know, what the patient's background, what medications they're on, and if you know what imaging tools are available for us.